So right now this is cardiology session, and we have two speakers, both very senior cardiologists. Dr. Viveka Kumar, who will be talking on cutting edge cardiac intervention in current era. And we have Dr. Gautam Nayak, who will be talking on transcatheter heart valve therapies, past, present, and future. So I'm just waiting for the moderator will be Dr. Inderpal Chabra, Dr. Rajiv Bhagiratha, and Dr. Harish. Doctor, you will be there? So may I invite Dr. Avinash Gupta to moderate the session. So he's a senior cardiologist at New Jersey, Monmouth Center. So sir, please start the session, and both the speakers' introduction is there in the booklet. So you can introduce first Dr. Viveka Kumar and request him to present. Thank you.
Good afternoon. We have two excellent speakers today on two excellent topics. So I can bet that you won't fall asleep post-lunch. Before I start, I would like to say something. Premature coronary artery disease is an epidemic in Indians. So I would urge everybody present here to take care of yourself and your family members as well as your patients. Kyunki nothing happens for nothing. I'm in practice for 30 years. I practice preventive cardiology, and none of my patients had a heart attack. And those who had a heart attack didn't have a second heart attack, because I take care of the blood pressure, the cholesterol, the sugar, ask them to stop smoking, and if they don't have any risk factors, if they have a family history, then I make sure that they take statins and do the advanced lipid testing, particle size, particle number, lipoprotein A, C-reactive protein, so homocysteine. So these are markers of high risk. And nowadays we have coronary calcium score. So please get everybody coronary calcium score, and if it is high, then see a cardiologist. So I say that people who go to cardiologists, they are the lucky ones. The unlucky ones, they can have a heart attack and they could die from it. So the first speaker is Dr. Viveka Kumar. He has an extensive experience in the field of cardiac interventions and electrophysiology. He specializes in complex angioplasties, including multivessel, bifurcation, and left main angioplasties with rota ablation, FFR, IVUS, IABP, Impella devices. He has done more than 7,500 angioplasties and 2,500 balloon valvulotomies with good outcomes. He has done more than 50,000 cardiac interventions, including complex PCI, rota, IVL, left main stenting, and multivessel PCI. Is structural heart disease expert, including TAVI, TMVR, left atrial appendage occlusion. He has done first subcutaneous AICD and maximum number of AICD implant in India. Maximum leadless pacemaker implant in India. Proctors national and international for TAVI, rota, IVUS, OCT, SICD, AICD, and MICRA. So looks like there is nothing he cannot do.
Well, so thank you, Dr. Arvind, for kind introduction. And briefly, I would just give you the glimpse of what is the change in interventional cardiology has happened. It's one of the most fast and rapidly paced specialty which has changed the landscape. From open heart surgery, we are going into the minimally invasive things. So this introduction slide in itself shows that at one point in time we needed to do open heart surgery to change the valve, which I think we are doing percutaneously without opening the chest, and the patients are going. So now we have ventured into daycare tower procedure. Some of the patients who have got complex blockages, we change, do the opening the blocked artery by stents. We have absorbable stents. We have bifurcation stents. Even the calcium we can do with the lithotripsy, which was in the realm of uh, for stone removal by urologists. Then, if you have to have pacemaker, we can give a 2 cc capsule kind of pacemaker, which will be lasting for almost 14 years, and without any scar, patient can go home in 12 hours. And people who are at a risk of atrial fibrillation and stroke and cannot tolerate the blood thinners, there we can give the appendage occlusion device. So if we go by the the basic tenet is that we thought whatever then open heart surgery or surgeon can do percutaneously, we can do better. So we have the whole basket of things like changing the valve, repairing the valve also. Mitra clip is something where I think my colleague would discuss. So then we can do the left atrial appendage closure, leadless pacemaker. So things are moving in a direction of minimally invasive and what we call with the keyhole procedure where the daycare procedures can be done. So this is the glimpse of what a surgical AVR would look like, the opening the chest and then going right up to the aortic valve. But here, if you see on the right side, just a small hole in the groin, and from there, under conscious sedation, while talking to the patient, we have changed the valve. So this is the beauty of this procedure, which is called tower procedure. Now we have got whole list of what was enumerated by Dr. Arvind, that the appendage closure, the leadless pacemaker, the ICDs, we do not need to go inside the heart. We can do subcutaneous ICD, so it will be externally placed between the skin and muscle. And then if everything fails, then we have got artificial heart, we can, which is called left ventricular assist device, and we have been doing it in, the largest volume in the country in our hospital. Absorbable stent came with a big bang that this disappears after 3-4, years. But now we have got access to second generation absorbable scaffold, and which is getting FDA approval now. But definitely this is something which is a revolution. So if you see what happens in a blocked artery, this is an artery where you can see furring of the artery. These are the cholesterol deposition in the artery and would cause chronic stable angina. But if the outer layer of this cholesterol plaque ruptures, the blood would clot there and cause acute heart attack. So how do we treat? We just pass a wire over the balloon. We will have a stent, and this stent will keep on releasing the drug for next 3 months or so to prevent the recurrence or restenosis. And this artery starts flowing normally, and within 6 months it gets endothelialized and it becomes almost near normal. We have a lot of patients who have got stenosis of the mitral valve. Once upon a time, everybody had to go for the open heart surgery or closed mitral valvotomy. We do it balloon mitral valvotomy on a regular basis for last 20-25 years. And the patients who have got so almost to an extent where the balloon mitral surgical mitral valvotomy has disappeared. And again, this is done under a daycare procedure where from the right femoral vein we do a transeptal puncture. The valve is narrowed and we just pass a balloon across it, appropriately sized. You don't even need an echocardiographic monitoring right during the procedure. And after ballooning it, the valve opens, and fortunately it remains open for quite long time. Mitral valve leakage is again a big problem, which I think in detail will be discussed by the next speaker. But the basic principle is that we clip the redundant part of the mitral valve so that the mitral valve prolapse, whatever is there, A2 or A2 P2 site or A1 P2 P1 size or something like that. So this is the clip whereby the redundant part is clipped. And again, it is not an open heart surgery. It is done under transesophageal guidance. Obviously, the patient has to be under general anesthesia. We do under 3D echocardiographic guidance, and this has really changed the landscape in this disease. So if you see the data, it is quite encouraging. So the patients who are really LV dysfunction, who cannot tolerate or open heart surgery, there you can see all the data that the severe mitral regurgitation can be brought to 0 or even less 1 grade, and then these patients would have. Then a lot of patients who have had a valve surgeries done in past, tissue valve, and then that tissue valve has failed. So in that also we don't need open heart surgery to remove the valve and then put a new one. We can do a valve-in-valve procedure whereby the old valve we size it according to the previous, size of the valve and do a CT, and then based on that we take a, new tower valve and then place, if this valve is in aortic position, we can change the aortic valve, and if it is in the mitral position, we can change the mitral valve as well. So valve in valve procedure is again something which is very promising, because patient does not have to take, redo open heart surgery. So this is one of the patient where you can clearly see the patient had a tissue mitral valve implanted almost 15 years back, and this patient was again, mother of a cardiologist in US. She was living in here, so she had a valve surgery done there, but at the age of 86, she was just not ready for any other, open heart surgery. There we have, do a transseptal puncture. We have gone into the old valve, and this is, you can, under transesophageal guidance, we did a, balloon dilatation of the old disease valve, and this is the balloon dilatation of the disease valve, and then you can see that we have, this is the new valve on the right hand side which is going in, and then that has to be under appropriate, positioning, that has to be inflated, and the magic is over. It starts functioning right there, and the patient gets discharged next day. So these are the advancements in this field. So if you see the, other de novo mitral valve space there, it's still not very successful, but right now we have got multiple valve option where the valve replacement can be done, though it's not got the FDA approval, but very soon that space will also be conquered. Aortic valve, as I said, it is the something which has become a routine, that if the patient has got severe narrowing of the aortic valve, that can be changed percutaneously. So I think we need a, heart team, a hybrid cath lab, and a suitable patient where the operative risk is high. So we started in India, almost 2016. In this case, we can go change the valve from, femoral artery, we can go from the, subclavian artery, even carotid artery. In one case, we had done direct aortic puncture where the patient had gone to OT and his whole aorta was porcelain, and the surgeon felt that he cannot clamp it, and we did the patient shifted on with the open chest in the cath lab, and we did change. So there are basically two types of valves. One is the self-expanding, and the other is balloon expandable. Now in this space we have got quite a few Indian companies also, and there we have we would change the cost has come down from almost 30 lakhs to, in the range of 10 to 12 lakh, and the valves can be changed. So these are one of the few cases where we have done. So CT scan is mandatory. I think Dr. Gautam will detail, these procedural detail, but in the interest of time, I'll skip these slides because there will be repetition with his talk. So basically on CT, we see how the sizes are, and then based on that, you have to do ballooning of the native valve, create a space, and then appropriate size valve is implanted there. So in this case, we had done one self-expanding accurate neo valve. You can see this patient was really very sick, and we had to stabilize her for 2-3 days, and this accurate neo valve was implanted, and then she got discharged after 2 days, and we have got more than 1.5 years follow-up, and she's doing absolutely fine. So if we, see the advantage of this, that this patient would never have had gone on OT table because she had such a bad lung, COPD, and this is a fully deployed valve where, with the aortogram, you can see there is no residual leakage in the valve, and the gradient has also 0. So this is a patient who did really very well. So in the interest of time, I'll not go into this thing, but this is how a delivery system of a self-expanding valve would look like, and the balloon expandable also. So in all of these, we go by transfemoral 90% of the time, or if the anatomy is not suitable, we can go again by subclavian or from the carotid. The aortic regurgitation and all still we are not, using on a routine basis, but we have done few cases where, pure AR is there. If the aortic size allows, we can use the conventional thing. Now, a lot of patients would have atrial fibrillation and they cannot tolerate the oral anticoagulation. And in those situations, even after ablation, if the patient has got recurrence of AF, then we can close the appendage, because the more than 95% of the clot would sit in the atrial appendage and can cause the stroke. So there we can put the aortic these appendage closure devices. So Watchman device and other, AMOLED devices are there. So a lot of devices which has come, but there are 2-3 which is approved by FDA, and this decreases the risk of repeat stroke, and even if the patient is not on oral anticoagulants. So again, the procedure is like we go by transseptal puncture, and with that we locate under transesophageal guidance the LA appendage and then put the device there, and the success rate again is 98% plus. And then the lot of patients who have got surgery done for tetralogy of Fallot or something like that, and pulmonary valve is leaking, we can implant the Melody valve. And then the tricuspid space also, these are the patients where the tricuspid valve is severely diseased, and you will remember that lot of them would have previous surgery, open heart surgeries or mitral valve replacement or aortic valve replacement, and most often than not they are elderly patients. So there we, if they have got severe tricuspid regurgitation, we have been using what we call bicaval valve, where the one valve is implanted into superior vena cava and one in inferior vena cava. So it neutralizes the tricuspid valve regurgitation. So a lot of patients with tricuspid valve who have got swelling in the leg, ascites, and the swelling, abdominal pain and all, there the volume reduction by diuretic alone is not sufficient. So there you can do the trick valve. Then coming to the pacing failures, there are a lot of patients who have got the pacemaker need. So as you know that as the age increases, the patient would need a pacing device, but quite a few of them would have occluded access. So subclavian vein both are occluded, or if that condition is there. And most importantly, in India also we see that quite a few patients who have got repeated infection of the pacemaker site. So in that situation, this is a miracle, because the Micra or leadless pacemaker is something where you don't need any lead, you don't need any scar. So the complication rates are 52% lesser, and implant success rate is nearly 99%. So in these situations, what we do is that we go from the right groin vein and implant so this is a patient who had recent surgery done and had third surgery done, this mitral valve replacement, atrial septal defect closure, then tricuspid valve repair. So this is how this is the delivery system of the leadless pacemaker, and this is the place where the pacemaker is sitting. So under the fluoroscopy guidance in cath lab, you can see these are the tines. So we try to fix the tines in the septal side of the right ventricle. So there it gets hooked and works for next 13-14 years. And if you need another one after that, you can implant up to 5 to 6 leadless pacemakers in the patient. And if it malfunctions, you can even snare it out. And coming to the subcutaneous ICD, so that like a pacemaker, ICDs are lifesavers. If the patient has got ventricular tachycardia or fibrillation, we implant these ICDs, which is just below the axillary space. So they are between the skin and muscle. So nothing goes inside the heart. This is again as effective as a transvenous AICD, except so this should not be given to the patient who need pacing also. So this is only for patients who have got LV dysfunction, ventricular tachycardia, and by virtue of this, the complication rates of this is also significantly less. And the beauty is again that all these devices can be home monitored. So patient does not have to go to the hospital for repeated monitoring. These all data can come to the patient's things. But as I said, that if everything fails, then we have got heart transplant. But since unlike kidney, where every human being has 2 kidneys, one he can or she can donate, there is only one heart. So you can do a heart transplant only in brain dead donors. So for that reason, you need an artificial heart. So this is a artificial heart, HeartMate 3, where we connect. It's like a Tulu pump. So you connect one at the apex of the left ventricle, it unloads it, and then puts it into the ascending aorta, and this continues like this, and the patient can lead a normal life. We have a longest surviving LVAD patient of 6 years. She is still doing well. There are certain other circulatory assist devices, but they work only till the patient is admitted in the hospital. So this is one of the patients where you can see the patient had LVAD and can walk, except for swimming and going into the water. He can do everything. So to conclude, I would say that, friends, the revolution in interventional cardiology is so much that most of the things can be done. We can stent the arteries, we can change the valve, we can put the pacemaker, and if the patient has got even gone beyond that, the artificial heart or LVAD devices can be implanted and they can live for longer, and probably that's the reason why longevity is increasing. So thank you very much for your kind attention, and if there is any question, I'll be more than happy to answer that.
Thank you, Dr. Viveka Kumar, for an excellent overview, a very comprehensive, like headline news. I am sure you can talk for an hour on each of those topics. But anybody has any questions? We'll take 2 questions. If not, then we'll go to the next speaker. Our next speaker. Oh, yes, please. Thank you. Our next speaker is Dr. Gautam Niloba Nayak. He is MD in General Internal Medicine and DM Cardiology. He did fellowship in interventional cardiology at Royal Papworth Hospital in Cambridge, UK, and structural heart intervention fellowship in Bart's Heart Centre, London, UK. He is a senior consultant, interventional and structural cardiologist in Indraprasth Apollo Hospital, New Delhi. And his topic is transcatheter heart valve therapies, past, present, and the future. Thank you.
If I may, before he starts, can I request everybody to keep your sidebar conversations to a minimum and to a whisper? Out of respect to our speakers, please keep sidebar conversations to a minimum. Thank you.
Thank you for the very kind introduction, sir, and greetings from Apollo Hospital. Thank you to the organizers for giving me this opportunity to present here. So as Dr. Viveka Kumar very eruditely put across the landscape of transcatheter interventions, I would just like to keep it as illustrative with minimal slides. So for the interest of time and for the lack of repetition that I need to do, I do not have any conflict of interest pertaining to this presentation. So valvular heart disease, just a brief overview. The epidemiology says that it's a leading cause of cardiovascular morbidity and mortality worldwide. Rheumatic heart disease overall still remains the most common primary cause of valvular heart disease. Degenerative and aortic and mitral and infectious etiologies are also very high in high-income countries. As per the European Society of Cardiology, the rheumatic heart disease incidence is a reflection of the economics of the country. So it is twice as high in high-income European countries. The most prevalent valve pathologies globally are rheumatic, followed by aortic valve stenotic disease, mitral regurgitation, and aortic regurgitation. So simply put, as we all know, it's disease of one of the 4 valves of the heart, which regulate blood flow from the cardiac chambers and to the great vessels. The 4 heart valves being aortic, mitral, tricuspid, and pulmonary valve. So there's basically 3 different types of valve disease. atretic means the valve doesn't open, but this is commonly encountered into childhood and the pediatric age group population. Stenosis means narrowing of the heart valve, so forward flow of blood is affected. Regurgitation means insufficiency or valve leakage, and all of these cause an increased load on the heart and subsequently heart failure. Symptoms are common to all forms of heart disease, which include dyspnea on exertion, angina, syncope or pre-syncope, dizziness, palpitations, fatigue. So they are very non-specific, which is why all the more reason to see your cardiologist early. And if it's right-sided, there will be ascites, ankle edema, and neck pulsations as well. A high index of clinical suspicion is required, as the symptoms may not be apparent until delayed diagnosis. Often the patient is referred to us for a heart murmur or any other clinical indication by the primary care physician. A physical examination by the cardiologist or general physician. Investigations include ECG, chest X-ray. As we all know, echocardiography remains the mainstay of diagnosis. CT scan is required for planning purposes, and cardiac MRI will help us in certain valvular heart disease cases, especially in mitral regurgitation, as we can see forwards. So as we all know, treatment options are primarily three. Medical therapy goes so far in regurgitant diseases. It's very common to start medications early, but in stenotic heart valves, it is of very little benefit. So essentially, we are left with two treatment options. One is the transcatheter heart valve therapies, which we are talking now about. And then obviously, open heart surgery still remains an option. So transcatheter heart valve therapies have surpassed surgery in the Western world. In America, it is about 53% incidence over 47 in 2020. In the last 3 years, there's been an explosion along with some trials which have come out, which have propagated this in the low-risk population as well. There's a similar rise in India. In transcatheter heart valve therapies, as put very rightly across by the previous speaker. Recent guidelines also have shown a trend towards transcatheter therapies. So let us come to the evolution of how it all started. About 60 years ago, the first open surgical valve was done as an open heart surgery. And in 1986, the first balloon aortic valvotomy was done. However, that as a therapy does not last long, so you need a more formidable solution for the aortic valve. Going forwards, there were similar revolutions until the first TAVI was done in 2002 in Rouen, France by Professor Cribier. And after that, there has been an explosion of transcatheter heart valve therapies, as you can see as you go further right towards the slides. In 2003, the first MitraClip case was done. And in 2000, the first transcatheter pulmonary valve was put in. There has been subsequent FDA approvals for various valves, which we will come to later. And in 2022, as recent as that, Dr. Kumar spoke about the MitraClip. There's the Pascal, which is from Edwards Life Sciences, which has received approval in the United States. Again, we can see that the evolution of TAVR and the timelines thereof. In 1988, this was just an idea which was born into fruition in 2002. And in the period between 2019 and 2022, a period of 3 years, more than 75,000 cases were done in the United States. It has been a truly transformative journey, and in the American College of Cardiology, there was a very nice editorial which outlined how the evolution has taken place. So what are the commercially available transcatheter heart valves in the aortic position? There's essentially the largest volume has been with these 5 valves. There are 3 self-expandable platforms and many more others, but the ones receiving significant CE approval and FDA approval are these 5. There are 2 balloon expandable valves. So essentially it's a metallic frame, usually nitinol, and either cow or pig, porcine or bovine pericardial tissue, and it's bone together just like the bioprosthetic surgical valves erstwhile used to be. Essentially, the valves that had started off on the balloon expandable platform. On the extreme right is the Sapien Ultra 3, and the new iterations are in the pipeline. There are subtle differences between the two platforms, but essentially what we need to know is that the self-expandable transcatheter heart valve from Abbott Navitor is novel in that it has an intra-annular design, meaning that the leaflets are built in within the frame of the aortic annulus, whereas the other two self-expandable platforms are supra-annular. And on the right-hand side, these are again intra-annular balloon expandable valves. Different anatomies are designed for different valves, and there are certain risk factors in which case we avoid or we prefer one valve over the other. A similar picture showing where the external skirt lies and what are the angio views. On the right is our very own indigenous My valve, which is Merrill Life Sciences India. Vapi, Gujarat is where it is based, and it had received CE approval in 2018. It is in vogue in Europe. In many countries in Europe and the UK, it has been used. And obviously, the use is very rampant in India. Initially, there were financial challenges, but those have been tackled, and it has come under the CGHS and the central gamut, leaving this therapy amenable for many. These are the self-expandable platforms that we have, and again, there are subtle differences with regards to where the skirt is put in and at what level do we place these valves, and the markers are different. On the right, there's a panel which shows the fluoroscopic views for each of them. For aortic regurgitation, when I was at Barts, we were the first center to trial this valve for aortic regurgitation in the UK. This has three locators. So the problem with aortic regurgitation is that the valve tends to embolize because there's no calcium catching onto the valve. This has been replaced by three locators. You can see on the right hand side on the fluoro image that they grasp the leaflets so that there is no embolization, and that shows a very good result in aortic regurgitation. However, it still hasn't received FDA approval and is still an investigational drug, but the recent ALIGN-AR trial has shown a lot of promise, and this might well be the way in the future for aortic valve regurgitation. Coming to transcatheter edge-to-edge repair, or what we normally call as mitral clip, because that was the only valve, only clip going forward. There are certain anatomical criteria. It is primarily used for primary degenerative mitral regurgitation, and then in secondary mitral regurgitation on certain preconditions. So the first in-human TEER or mitral clip was done in 2003, and then there was Everest 2 trial which was published, which showed that it was non-inferior to surgery. This was done in 2011, after which in 2018 there were a couple of very pivotal trials called COAPT and MITRA FR, which gave us a lot of information as to how to best use this technology. And as I said previously in my slide, in 2022 there was FDA approval for the Pascal device as well. It's still not available in India, but we hope that as more and more cases are being done, we will get this device. So these are the two systems that are available to us. The fourth generation, there's the fourth iteration of the MITRA clip, and then there's the Pascal system wherein you have a steerable guide, and they are similar in many respects, but different in some. I won't go into the details for the lack of time. Let us come to transcatheter mitral valve implantation or replacement. So not only can you repair the valve, you can also replace it. Erstwhile, it was done by putting the same aortic valve in the mitral position, but now there are dedicated systems in place, of which the most interesting is the one on the left lower panel called the EVOKE, which has recently received FDA approval for tricuspid regurgitation and is expected to, and the initial data are very promising. So there are dedicated systems because the mitral annular anatomy is very complex. And it is a dynamic D shape, which is very different from the aortic valve complexes. So what are the other valves that we have? One is the evoke system, as I had already alluded to. Balloon systems are still used in the mitral position, but can be used in other positions as well, such as the pulmonary and tricuspid position. And there is this trick valve, which is essentially putting two different valves into the superior vena cava and the inferior vena cava to halt tricuspid regurgitation, and they have shown early promise. So lifetime management and future direction for these patients is, as people are living longer, we have to have a strategy in place. If a patient gets a surgical valve first, then there are challenges as to how you plan future transcatheter procedures and vice versa as well. So the future directions would include valves which have increased durability, which facilitate coronary access, because the cells in supraannular positions have a difficulty in engaging the coronaries. So the technologies are working towards how we can improve this. And then there is a 4 to 8% chance of a permanent pacemaker implantation with a TAVI. We are trying to bring it down to as low as possible. And artificial intelligence will also play a role in the future. So much so that in 2023, we have seen that the barrow has already shifted towards transcatheter therapies, and as there are more and more refinements, there will be more and more TAVIs taking place. These are a few list of conditions where there are unknown or gray areas, but more and more people are opting for a less invasive option, and that's where these transcatheter therapies come into play. So what's the future? AI assisted TAVI. So AI can assist us in planning for these procedures. What are the applications that can going forwards? You can superimpose your transesophageal images in these procedures over and above your fluoroscopic images, and then you can give the implanter a bird's eye view as if he's doing the procedure before he's even doing it. Then there is robotics in transcatheter technologies. I at least know of one company in Europe which is working towards this. And then there are dedicated devices for transcatheter, tricuspid valve diseases. And then there is virtual reality, as I said, in planning these procedures. When you go out for symposia, there are various companies talking about just this. And then there is telemedicine, where we can have a collaboration between different continents and doctors from different places, where we can think about the patient as a holistic and take a holistic approach of it. This is more of a personal note. This is St. Bartholomew's Hospital, where I was training in London, and hopefully I have made friends for a lifetime from there. The Indian touch to this would be that the Indian diaspora, as I can see it from both quarters, there's a cultural bond that binds us. There's a yearning for our land of birth. There's a huge success stories of Indians living abroad. They are the most successful ethnic minority if you see in the UK and US. They are contributing equally towards India's growth and progress and putting India on the world map. Why I decided to come back? There was potential for personal and professional growth. There is economic boom in India now, and the era of digitization has evolved. There is national pride at our recent achievements, and as we can see on the right-hand side, we are now on the moon. The ability to contribute in a small way to the success story of India and to reclaim our rightful place in history with a grand vision for the future. Now, I would like to thank Apollo for giving me this opportunity, and I'd like to end my talk here. Thank you very much for your kind attention.
Thank you, Dr. Gautam, for a nice, excellent presentation. There was a time when we didn't know what to do with 80, 90, 100-year-old with aortic stenosis, and now we have TAVR. So we usually do TAVR in patients who are more than 75. Is there a cutoff?
So,
here?
sir, what has happened now is that the guidelines in the US state that more than 65 years of age, you can consider TAVI in those patients. So those are the latest guidelines. So US says 65. In Europe, it is 75 and above. TAVR is preferred over SAVR. So it's 65, 75 in both those continents. Presumably because people live longer, but when we used to have our MDTs in in the UK, we used to discuss these patients, and we felt that if the patient is above 60, then we debate the benefits of doing a transcatheter valve. If he has significant comorbidities, the referral pathway used to be such that we used to have patients with advanced liver disease, and if they are young, then we would still offer them TAVI in those particular patient populations.
Yeah.
Yeah, for tricuspid disease, as I said, Evoke has recently been launched and approved. We use the trick valve, or we can use the valves which are in the aortic position for the tricuspid patients as well. We do have a case lined up for just that at Apollo.
And timing of valve surgery is very important. You don't want to do it when they don't need it, but you don't want to wait. Otherwise, there will be dysfunction.
Yeah, so with that, I mean, again, looking towards the future, that is something. There was a seminal talk by Dr. Martin Leon very recently, which I listened to very intently. And what he was alluding to was we look at aortic stenosis. By the time the patient presents to us or is symptomatic, he's almost always downhill. So is it like a continuum disease, or whether it's a end-all game where the current guidelines say that we have to intervene only in severe symptomatic disease? But what about the asymptomatic patients? There's a Vmax criteria of more than 5 meters per second for those particular patients. And if there is LV dysfunction, obviously you give them the benefit of this. But should we look at, and at BARTS, we had a trial of moderate aortic stenosis, the Evolute FX, which has just come into play. They are trialing whether moderate aortic stenosis, there's a benefit in intervening at an early stage. Right now, there are only, surrogate markers, just like GLS, global longitudinal strain on the echocardiogram, or whether you have a BNP which is higher or lower, and that makes the decision. But these are gray areas and not defined by guidelines, so I would be hesitant to, recommend them that.
And the first symptom may be sudden cardiac death.
Yes. The symptom can be sudden cardiac
Yeah.
death as well.
Thank you. Anybody
Thank
else
you.
has any questions? Okay.
Thank you so much. I'll request you to hand over the memento to Dr. Gautam Nayak, please. Dr. Bhavani, can you join, please? Yeah. We have Dr. Anjana also, so I request her to join, to hand over memento to Dr.